Hi, I was wondering if you guys could hear me now. Okay, so you guys can hear me now. I'm going to get started. Um, so indications for arterial blood gases. We use them to monitor gas exchange. That's one of the main reasons we do arterial blood gases. So we see if anyone's or if their PaO2 is low. We also use it so ventilation wise. So like if your CO2 is low, it tells us how you're ventilating. If it's low, then you're blowing off your CO2, and if it's high, then you're um, not working and blowing off as much as we'd like you to be. It can also show if there's like an imbalance to the pH, so it could be medical respiratory wise. And we also use it to assess treatments or patients' response to treatments and their progression and severity of their diseases. So when we go to get arterial an ABG, we go for either the radial artery, the femoral artery, or the brachial artery. Our preferred spot is the radial artery in the wrist. It's easy to get good collateral circulation for the most part from the ulnar artery. And you can test this. You can test the collateral circulation by doing a modified Allen's test. So all you do is you go with the wrist and you just occlude both arteries and you get them to open and close their hands until their hands wide it out, and then read and see if they have if their hand pings up within like 15-20 seconds. If the patient is sedated or unable to do so, you can actually white out the person or the patient's hand themselves or yourself by occluding the artery and just rubbing the hand until it's white. And then doing the same thing and letting go of the ulnar artery. You can also that's the preferred method is to white it out yourself, but you can also put the sat probe on their hand and include both arteries and watch if their waveform disappears. And if it does that you've occluded both the arteries, and then once you let go of the ulnar, it'll show if you've got a good flow going back into that hand. Some contraindications to arterial blood gases are negative Allen tests. You got to have good collateral circulation there. And you shouldn't do it in an arm that has a shunt in it. It could just affect the results and stuff or the shunt itself. If a patient is taking anticoagulants like heparin or warfarin, you should be aware of that and what their clotting factor is. And that's just a relative contraindication, not a contraindication to arterial blood gas. So when you go to interpret ABG results, your pH, a normal pH is between 7.35 and 7.45. Anything a pH above 7.45 is alkalotic, and anything below 7.35 is acidotic. A normal CO2 is 35 to 45 milligrams mercury. PaCO2 above 45 is acidotic, below 35 is alkalotic. So if you've got a pH of 7.28 and a CO2 of 50, then that will be a respiratory acidosis, or opposite. They could be both alkalotic, or CO2 could be low and the pH will be high. That'll be a respiratory. A normal PaO2 is between 80 and 100 milligrams mercury. also take that into mind, take into consideration of their age. We accept lower AO2 levels for people over 65. So for every 5 years over 65, we take off um, five, like subtract five from the value. So if someone's PaO2 is and you want their PaO2 to be 80, it'll probably, or like, not if you want it to be, but you'll probably see like a normal PaO2 will be 75 for them. And then a normal bicarb is 21 to 26 milligrams of mercury. When you see, so if you go and you look at a ABG results and you see that your pH is off, you may have a normal pH. Your bicarb will be like 35 and your CO2 will be, I don't know, let's say like 60. That's probably a compensated ABG for that person, and that person could have COPD or a number of lung diseases that will cause them to have a normal, like that will be their new normal. Um, Bicarb doesn't just increase in a day to 35. Bicarb that's higher than 26 and it's in the 30s, then you're going to see that happen over a few days, if not a week or two. So it's not an acute thing causing the bicarb to be increased. Um, if the pH is normal, but then both the bicarb and the CO2 is abnormal, then that is a compensated gas. Uncompensated is when the pH is normal and the bicarb or the CO2, or one of the bicarb or CO2 is normal as well. So when you look at a gas, if the pH is normal, you want to try and treat what's causing or figure out what's causing the pH to be abnormal. Preferably, we like the pH to be normal, even if CO2 or bicarb may be off a little bit. Um, so if you, again, with the patients with COPD, if you see them come in and the they have the increased bicarb and the CO2, another thing you've got to be really careful with is there's this theory called the hypoxic drive theory. So when we breathe, we have central and peripheral chemoreceptors. So central chemoreceptors respond to CO2, and the peripheral chemoreceptors respond to PO2. So if your CO2 is high, receptors, if it's high, then you'll breathe faster. So the central chemoreceptors essentially regulate how fast you breathe depending on how much CO2 you have built up in your blood, whereas the peripheral respond to how much oxygen you have in your blood. So if it's high, then it'll probably blow it off or work it through your body faster. If it's low, then it won't as much. So people that have a high CO2 in their blood normally, like that's a normal thing for them, and giving them high levels of oxygen, because at that point where their CO2 levels are normally high, their central chemoreceptors can like become overstimulated, I guess, and just stop kind of working. So it's not that they'll stop working, but they'll become used to that high level of CO2, so they won't respond as quickly as if you had a normal CO2. So then your peripheral chemoreceptors are the ones that will actually have give them a high level of oxygen. It could actually make them go apneic or depress their respiratory drive. Um, that's not it's not very common, but keep it is something you should keep an idea of, just because a lot of COPD patients, you will see have you'll see them have like order their SpO2 orders to be 88 to 92, depending on the severity, or above 90 for them. Um, so yeah, you'll just see that those orders and stuff. So you just got to use them. So like I've noticed sometimes, like over the past year and stuff, going out into the hospital, people try to wean. You got to know if people are on a home oxygen or anything. Because I've seen people think they need to wean the oxygen on this patient who already is at their normal home oxygen level, but they're trying to wean down below that. That's not really something we assess when they're in hospital. It's more something the home care people assess outside the hospital and adjust as we go. We have home oxygen assessments for that quite often, actually. So, like, if someone's in the hospital and we can't wean them and we suspect that they need home oxygen, then we'll do a walk test. We'll also do the walk test at PFT labs and stuff. So, with that walk test, we also use ABGs quite often for that. That's actually the criteria where we do the physical walk. So, like, if we take an ABG, we start the home oxygen assessment with an ABG, and we go, and if the PO2 is less than 55 milligrams mercury on room air, then we will we'll walk them. So we'll see if their sat drops below 88 or whatever while they're walking, and if it does, we have to try titrate there to be like greater than 92 on whatever the oxygen is, and keep it above there as we walk, and that determines how much oxygen they need. We also get a post gas after the walk to see if that raised their CO2, and it'll just help us determine like what they may need on top of the oxygen, if they really need it on exertion or not. And some people don't need oxygen at rest, but they need it for exertion. So that's why we walk people on room air a lot. Even if they don't have like that low VSAT when we start out and things like that, or like the PO2 is a little different. Or like a little between a certain level and above, it might be like at 55, but they're sat like 94. So if it's on exertion and their CO2 goes up, then they need on exertion. But if their sat's okay on room air, then we won't make them have it on even at rest. Um, to use for like CHF, so congestive heart failure patients or pulmonary edema, we use BiPAP quite often. So if you have a patient come in to emerge or something, or if you find a patient like abnormally lethargic, like that's not their normal cells, that's not the way they normally are, then you can take a look and maybe get an ABG ordered, or like see what their SAT is. If their SAT's low, then we'll come and get like an ABG, and it could mean that they get really sleepy, maybe not really coherent. They might not be easily rousable. So we'll get an ABG. If they're too far gone, then we can't use BiPAP, and we're going to have to intubate or look at a different intervention there. But they've got to be like appropriate to be on BiPAP. We can't have them on BiPAP if they're nauseous. But a big thing that we use BiPAP for is, it's not ventilating them, but it kind of is. It has a set rate, so it'll help open the airways a little more, help them get that air in and out, and blow off that CO2. If that doesn't work, then we do intubate them, and we help them breathe that way for a little while until we can extubate them and rest their respiratory muscles and stuff. And also with CHF and pulmonary edema, where they have fluid, most likely have fluid backup. So the BiPAP and the extra pressure coming from the BiPAP can kind of help ease some of the fluid in their lungs and like push it back to where it's supposed to be. Um, if someone's got a high bicarb, you got to take a look into account if their renal and liver function is normal. You got to look at their urine output and if they're actually peeing. Look if they're on Lasix or anything. So they may become edematous. They may be retaining that fluid. Like that's a big factor is the metabolic system. So you got to look at the kidneys, you got to look at the liver because we as respiratory therapists we don't really look at that. It's more so nursing and doctors that look at it because they can actually you're actually able to give Lasix and diuretics and look if they maybe need dialysis or what else is going on, what's causing that bicarb to be high. And it's not going to be a quick fix. It's going to be a fix over a few days. Uh, and the respiratory system definitely compensates faster than the metabolic system, so you can easily blow off CO2 way faster than you can decrease or increase your bicarb. If a bicarb is low, um, and it could mean that like they could have came in if they come in with a low bicarb. Look, do they have diarrhea or have they been vomiting? Like you gotta look at stuff about how they're getting rid of their blood and how it's getting out of their body. Um, so you got to look at that. And in the ICU, we'll actually give bicarb. The patient will be given bicarb infusions. Um, so yeah, I think that's everything I have for this. If you guys have any questions, just comment or type into the live stream. And like here if you do have questions. But yeah, that's my top for now. If anything was unclear to you, then we'll just see if it's good. Okay, everything and no other questions, then I will let you go. Bye.